elevate all the soft tissue of the bone. Okay, and look, here is a venous channel. This is a emissary vein. Okay, can you see it? This is the emissary vein.
No, out of
it is
field.
Out of focus. Okay, out of the area. Now,
yes, visible.
Because in live surgery also, if you go far posterior from the cortical bone, you will encounter a torrential bleed from that area, and this is the emissary vein. And depending on the anatomical variation, some patient there will be a larger channel, some patient there is small channel of this emissary vein. And one thing, you cannot cauterize this bleeding from that emissary vein, because this is a wide channel and that is going deep into the bony cavity. So controlling this bleeding sometimes very challenging, and so you have to put some bone wax to control this emissary vein bleeding. This is a very important task. In sometime regular cortical mastoidectomy or temporal bone, you will not encounter this vein, but sometime in cochlear implantation or in lateral skull base surgery, when we have to raise a very larger flap, we have to encounter this vein, and for that we have to prepare with a bone wax to control the bleeding of the emissary vein. Now look at the anatomical surface marking. What are the surface structure or what are the anatomical landmark that defines the cortical area of the mastoid bone, or where is the actual location where you go through the cortical mastoidectomy. So this is the anterior part, this is the external auditory canal, this is the inferior part, this is the superior part, and this is the posterior part. Okay, so orient yourself. This is the superior, this is the inferior, this is anterior, and this is posterior. So now just behind the external auditory canal, in the posterior canal wall, you will have a notch, and this is the spine of Henle. And depending on the anatomy, in some patient this is very prominent, and in some patient that will be very rudimentary, but in any cases you will find a notch over there, and that is the spine of Henle. This is a very important landmark for every dissection for the otologist, because it directs the actual canal and it will show where you have to go for the cortical mastoidectomy. Then what are the other landmarks? Look, this is the landmark for the tegment plate. Okay, so this is the linea temporalis, the attachment of the temporalis muscle, the lower border. This is the attachment of the temporalis muscle, that is we call the linea temporalis, that actually correspond to the level of the tegment tympani and the tegment antri, the middle cranial fossa. Okay, and inferiorly this is a tangent line. If we will draw a line from the inferior part of the posterior canal wall, then we will find this line that will cross at the end at this synodral angle. So here will be the synodral angle. This is the inferior aspect, this is the superior aspect, and here is the canal wall. So this triangle is called the triangle of attack, or this is the actual area where you have to start drilling for cortical mastoidectomy. Okay, so now in this patient, after elevating the soft tissue flap, now put your mastoid retractor in the superior part, because this is the larger flap and the length of this mastoid retractor will not be sufficient if you will apply in the middle point. Okay, so that's why you have to apply the retractor in the upper part and maybe sometimes in the lower part if you will continue dissection in the tip cell area. So now we will start dissecting for the cortical mastoidectomy. So for any temporal bone dissection or any type of mastoid surgery, the first thing is the cortical mastoidectomy. Okay, because this is the entry to the mastoid or the cortex of the mastoid bone, and from that part you may enter into the lateral skull base, you may enter into the midlayer cavity even without opening the tympanic membrane. You can also dissect the other associated important structure like semicircular canals in case of labyrinthectomy, vestibular nerve in case of lateral skull base surgery, facial nerve for facial nerve fractures or facial nerve paralysis. In case of glomus jugulare, you can directly dissect up to the jugular foramen. So various parts of the skull base and the middle ear and the tympanic cavity can be approached through this cortical passage. So first thing, you have to do a wide cortical mastoidectomy. But in our case, when we do a cortical mastoidectomy for a COSM or a infected case in day-to-day practice, whether we need to do a larger mastoidectomy or not. This is a very important question. Every day we have been asked from our student colleagues and everywhere that during a COM surgery, whether we need to do a wide cortical mastoidectomy or we open just up to the mastoid antrum. Actually, this drilling process is not just doing a just bar hole, just you are opening the cortical mastoid or cortical antrum. You have to identify the associated structure like the sigmoid sinus, you have to identify the superiorly the tegment plate or the middle cranial fossa, and then you will enter into the cortical bone so that you will reach the mastoid antrum, because in some cases there will be very rudimentary antrum, there may be very sclerotic mastoid bone. In that cases it will be very difficult to identify. So from the very beginning, don't do a bar hole or small opening mastoidectomy practice. You will always try to dissect from the all the structures so that you can identify each and every landmarks, and then you will go inside the cortical bone. Okay, so let's start. First we will demarcate the line of drilling. So this is the superior part, the tegmen area. So this is the linea temporalis. So first cut will be linea temporalis. Okay. Next, the second part will be the posterior canal wall, just posterior to the spine of only. Look. Okay, like that. And the third cut will be the tangent line from the inferior border of the canal wall to the first line of the linea temporalis that will merge at the synovial angle. So this is the boundary of the cortical mastoidectomy, and this is called the triangle of attack. So in that triangle you will safely, you can drill up to the mastoid antrum and you will find the landmark like lateral canal, like digastric ridge, posteriorly the sigmoid sinus, superiorly the tegmen antri, etc. Okay. So now we are drilling the cortical bone. So first always demarcate the line of drilling, and then you will remove the cortical bone layer by layer. Okay. For demonstration purpose, I am using this dumbbell shaped bar because we will remove the bone very quickly, but for your dissection you will get the round bar obviously, so that slowly you can drill without damaging any important structure, because we have 3 days training time, so you can have some time and go slowly up to the cortical mastoidectomy. Okay. So this is the cortical bone you are drilling, and look the honeycomb pattern, the cellular architecture is coming. This is all the
quite a pneumatic mastoid.
Pneumatic mastoid. In majority of the temporal bone dissection, we get the pneumatic mastoid, and in some cases definitely very contracted or COM cases are there, because in normal population there is some occurrence of COM definitely, and in dead bodies we will definitely get some COM. Some cases we have found the tympanic membrane is perforated also. So this is not very uncommon. So in every cases you have to delineate the important landmarks, and when we go step by step dissecting all the bony architecture to identify the landmarks, look the direction of the drilling. In the tegmen, when in the superior part, you will drill along the tegment plate like that. So this will be your direction. Slowly and smoothly you will go through and fro according to the direction of the important structure. When we come into the posterior part toward the sigmoid sinus, we will drill like that according to the direction of the sinus or the sinus plate. So the direction of the drilling or the rotating bar should be parallel to the important structure. Okay, and always try to drill slowly. Don't be in a hurry. Don't do any jerky movement over the temporal bone, because that can damage the surrounding structure, because all the important vital structures are very close to your drilling area. Okay, so this is the cortical bone. We are drilling all the cells. We are trying to accentuate like that. So look. Okay, wall पे पूरा. In between you have to give some wash. So for that we have kept some syringes. So when you are drilling, there will be constant irrigation from the your saline set, and intermittently when there will be some accumulation of bone dust, you will give some copious irrigation to remove all the dirt, all the bone dust over the dissection area. So that will actually clear the field and increase the visibility of the area. So that is very important, because if there is some bone dust, if there is some accumulation, you are still doing drilling, so you can miss some landmark and ultimately land up with a big damage. Okay, so like that you will go. So in that part you will not directly enter into the cortical mastoid, because if we drill here we can directly enter into the cortical mastoid, but that is not actually the cortical mastoidectomy. The idea is you have to identify the landmarks before entering inside the cortical mastoid. Sometimes we say that first we enter into the cortical mastoid, then we will enlarge the cavity. So that is not actually the thing. If you have entered into the cortical mastoid without identifying the lateral landmark, you can damage at that time. So if the damage already has been done, then what is the role of enlarging the cavity? So from the very beginning.
Harisandra, can I add one thing?
Yes.
It's not always that we do a pre-op CT scan and we know the position of the sigmoid and the tegment.
Yes.
So if you try to do a small hole, then it is very likely that you can end up injuring that. No?
Very difficult. And this is a very important topic. Previously, we have certain indications for mastoidectomy CT scan in COM cases. They will do in pediatric patients, will do in complicated cases. Give some water here. So, but nowadays, as the CT or moreover the HSCT or thin slice CT has been available in every hospital very easily. So, in each and every cases where we are planning for a mastoid surgery, we always advocate a CT scan for the patient, because CT scan doesn't give you the diagnosis actually, whether it is cholesteatoma or not. CT scan will not tell you, but CT scan will identify, CT scan will show you all the important landmark that you will encounter during surgery. So that is actually the surgical roadmap you need for your surgery. So for that reason, in each and every cases of mastoid surgery, nowadays we are doing CT scan. Previously, X-ray was very helpful to identify the level of the tegment and the sigmoid sinus. So if you know the actual position of the sigmoid, actual position of the tegment, then it will be very easy to dissect during the surgery. Okay. Okay, sir. Anything else?
Yes, for now, boss.
Yes. Now we are continuing with the dissection. Okay. 1 second. The sucker has been blocked. So this is a very common thing when you are drilling the cortical bone, as there is a large bone chips are there, so it's very commonly get blocked. But whenever you will enter into the inner into the medial part of the dissection, and then the blockage will be very less, because there will be very small bone chips and the bone dust will be there. So in the first part, go very slowly and cautiously, do not damage any important landmark. So now we are coming to the sigmoid sinus. So whenever you are doing a temporal bone dissection, few things always keep in mind. First thing is the sound. When there will be important landmarks or a hollow structure is coming, the sound of the bar will be changed. This is the first indication that you are coming towards the important structure nearby. Okay. The second is the color change. In temporal bone dissection, in the dead body or this cadaver dissection, this color change sometimes doesn't help you, because there is no actual blood flow that gives the color. But in live temporal bone dissection, live surgery like cortical mastoidectomy or canal wall up or canal wall down mastoidectomy, you will always have this color change very beautifully. You can see the pink color of the tegment tympani or tegment antri, the sigmoid place with the bluish tinge will be there, jugular bulb will be the same. So all the landmarks and their color change will be very prominent in the live surgery, but it is not actually very evident in temporal bone dissection. So in that regard, temporal bone dissection delineating all the anatomical structure is definitely difficult than a live surgery, because there will be bleeding, there will be sentinel bleeding. You will have some clue every time you dissect the anatomical part. But in cadaver dissection, these bleedings are not present, so that will be very easy to dissect definitely, but this sentinel bleeding will help sometimes the surgeon to identify the critical structure that will be nearby. So we have already delineated the sigmoid sinus. So this is the sigmoid plate. So this will be the mastoid anteromedia, and here we will delineate the middle cranial fossa or the tegment plate. So look the direction of the bar. Always use your bar in the correct direction. So that will minimize the trauma. That will minimize the trauma. If you use your bar in a faulty direction, then it can cause the damage very easily. So this is the area
Every time
of
the bar is visible, total bar is visible.
yes, always, because it has a 360 rotation, na. So always try to make that the contact will be on a single surface, not on that side, not on that side. So if the contact will be on the both sides like that, then the bar will be jerky. There will be some jerky movement, and that can actually damage. So always keep your eye on the rotating bar. That should be in the proper position, and the contact will be on a single side of the bar, not on the both side or not on the surrounding structure. Okay. So now we are opening the cells so that we can go into the mastoid antrum. Okay. So this is the the sucker is not functioning properly. It's blocked. Funny. Okay. The suction is a very difficult thing in cortical mastoidectomy sometimes. If you have a blocked suction apparatus, then it is very time consuming. Okay, now give wash. So this is where getting the tegment. I am going by dissecting the important landmark. We have already identified the sigmoid sinus. This is the sinodural angle that is coming. So this will be the tegment. So this is the tegment. Okay, you can visualize the some blood vessels over there. and like this is the drilling, this is the sound, and this is the sound. The both sound you have some difference, and this difference will tell you the important landmark of the hollow structures are very close, and at that time you can minimize the speed of the bar, you can change the rotation speed of the bar, you can change the size of the bar, okay, so that you can minimize the damage. And one more thing, we always delineate superiorly the tegment, posteriorly the sigmoid sinus, but we always fail to delineate the canal wall, and that is very important for further work. If you are going for a cortical mastoidectomy for cochlear implantation, or if you are going for a facial recess surgery for any other reason like glomus surgery or anything, combined approach tympanoplasty, then the canal should be absolutely delineated, okay. So these are all cells, and after that you will get actually the canal wall. Otherwise you cannot delineate the facial recess because it will obscure the view of the facial recess area. So this is how you should go for a cortical mastoidectomy. Don't directly jump into the mastoid cavity or do a bar hole. First delineate the landmark superiorly, posteriorly, cerebral angle, and then slightly go into the anterior part to delineate the canal wall and make it thin as much possible, but don't destroy the canal wall. And this is a very common mistake in cortical mastoidectomy, because if you damage the canal wall, then the whole thing is damaged, because it is a canal wall up surgery. So you have to preserve the canal wall properly, so that when you do your reconstruction, when you do your tympanoplasty, it can protect the mastoid cavity from the external canal. So this part is very important. So look, this is the canal wall, and look at the position of the microscope. It should be vertical on the external auditory canal, so that you can visualize the external auditory canal and the mastoid cavity. So both the cavities should be visualized from the head-on direction, so that you can assess the thickness of the external auditory canal. Otherwise you cannot judge. If your position of the microscope like that, then you cannot understand the how much the thickness is there or how anterior you can go. So for cortical mastoidectomy, you have to put your microscope in the proper alignment. There should be a proper head-on view, so that you can assess the thickness of the external auditory canal. Now we are going towards
At this point, can you say something about the corner septum?
Yes, in that patient the corner septum was not present, but sometime this is a anatomical remnant or embryological remnant, that the lateral and the medial cell in between there will be a septum like structure, and that obscure the view of the mastoid antrum, and in that cases we usually think that we have reached the mastoid antrum, but actually the mastoid antrum is medial to the corner septum. So that is also a very important aspect of doing CT scan, because in live surgery you can definitely define the cortical corner septum and the mastoid antrum clearly, but if you have the knowledge before the surgery by seeing the CT scan, it will be very helpful, because sometimes we see that there is a septum like structure or a straight bony septum that lying over the mastoid antrum, and you will be thinking that whether you are going medial or drill it or not. So this dilemma will come if you don't have the CT scan beforehand, and if you have the CT scan, then it will be very easy to understand that yes, it is a corner septum, and you can define the actual level of the mastoid antrum. So look, now we have entered the mastoid antrum, and what is the first landmark? What is the first landmark of the cortical mastoidectomy? The first, in the mastoid antrum, we can visualize the lateral semicircular canal in the floor of the mastoid antrum. So this is the lateral semicircular canal. This is the first important landmark into the antrum cavity. So this is the mastoid antrum, this is the posterior epitympanic cavity, and this is the lateral semicircular canal. So this is part of the mastoid antrum. Now we will go for inferior to dissect all that area of the tip cell. There will be two groups of tip cells, the lateral tip cell and the medial tip cell. When you drill the tip cell, you will identify another important landmark, that is called digastric ridge.
Hello, sir.
Yes.
What should be the ideal thickness of canal wall in cortical mastoidectomy?
Ideal thickness?
Yes.
Yes. Look, if you identify the lateral semicircular canal as well as the facial recess area, then it is good. In many cases, the canal is not straight. This is a very tortuous structure. There will be some harm. So, this measurement doesn't help every time, because the canal architecture will be different in patient to patient. So always you have to dissect up to the facial recess area like that, and that will be the actual thickness of the ethmoidary canal. And definitely it depends on the type of surgery you are performing. Suppose you are doing a cortical mastoidectomy, then this thickness might be okay, because you have excentrated all the cells. You will go for inferior and you have identified the lateral semicircular canal, you will go in the epitympanic cavity, that is the actual disease process started over there. But suppose you
Hello. Hello, sir, you are not audible.
hello, hello, now you can hear me? Hello?
Yes, sir.
Yes, yes. So suppose you are doing a cochlear implantation, and in that case you have to make the canal wall just like a paper thin thickness, okay, because otherwise you cannot visualize the middle ear through the posterior tympanotomy, and you cannot approach the round window area. So the thickness of the posterior canal wall depends according to the situation, according to the surgery you are doing. Okay.
Hello, sir.
Yes.
Sir, while drilling, while I am approaching the lateral semicircular canal,
Yes.
how to differentiate whether it is a sclerotic part of the mastoid bone or it is actually lateral canal?
Okay, okay. The first thing, the lateral canal has a smooth surface in the floor of the mastoid cavity. Second,
Hello, again you are not audible, sir. Hello. Hello.
hello.
Hello.
Yes, actually the talkback might have some problem. That's why there is a frequent disconnection. Yes, in case of normal day-to-day surgery, look, the color of the otic capsule bone and the surrounding bone is different. Okay, so the density.
Hello.
Yes, yes. Hello. Hello. Hello.
Yes, you're audible.
Yes, yes. Actually, the mic is not properly functioning. That's why we have some problem. Yes. So the color change is definite in case of the mastoid bone or the sclerotic bone, and the color of the otic capsule. There is a gross difference. So that will help you identifying the lateral semicircular canal from the other part of the bone in the mastoid antrum. Okay. Look, this is the lateral tip cell bone, and we are going drilling this. Look, there is a jerky movement of the bar. This is why what I am saying at that part, when you touch both the surface of the bar with the bone like that, then there will be some jerky movement. So always try to make sure that one side of the bar is in contact. But in these situations, when we are doing the drilling in the tip cell area or in the spanural angle, there will be a chance of some jerky movements. As this is the larger bar, you can change it to the smaller size of the bar so that the drilling will be smooth. But for faster drilling, in that part we always use some conical larger bar, and after we have reached our landmark, then we can change into the smaller bar according to the need. So this is the canal wall, and we are removing all the cells from the external canal wall from behind, and we are drilling the tip cell area. Okay, so look, this is the dimension of the cortical mastoidectomy. In day-to-day regular surgery, you should drill like that, removing all the cell, because if there is a infected cell in the tip cell region or there is some accumulation, that should be clear that this is the idea of cortical mastoidectomy. Though the principles and idea of cortical mastoidectomy is changing day by day, the basic thought of doing a cortical mastoidectomy in case of the COMs where the middle ear is not getting dried in spite of having multiple times of antibiotic therapy or the eardrop you are using, then you should think about opening the cortical mastoid at the same time of doing tympanoplasty or tympanic membrane reconstruction. Because if the mastoid ear cell is infected and there is accumulation of some debris, then it is very important to remove all the cellular system so that you can remove all the accumulated debris and the infected particles from the cellular area. But there is another school of thought also. In majority of cases of COM, the actual block is in the anterior part, in the opening of the eustachian tube, in the epitympanic space where the ventilation pathway comes from the eustachian tube to the aretas and the mastoid antrum, and in that region you have some block, some hypertrophy, some granulation, the effect of COM that leads to the complete ventilation block of the mastoid antrum, and in that cases the drilling is required. Okay. Okay. So, since this is a theory that in every cases of infected cavity or COM, you should go for a cortical mastoidectomy, and there are thousands of study, thousands of research has been done whether cortical mastoidectomy is beneficial or have any extra edge over the simple tympanoplasty in a COM patient. But till today, there are two group of surgeons. One believe every cases you have to do cortical mastoidectomy to exentrate all the infected cell and clear all the debris so that the ventilation has been established. And another group of surgeons, they always have a say that cortical mastoidectomy should not be done in every cases of COM because it not only jeopardizes the cellular architecture of the mastoid cavity, all the cellular system has been lost, because whenever you are doing cortical mastoidectomy, you are exentrating all the cells. So actually the cellular system has been lost, and after some years there will be some fibrosis. So actually the gas exchange system that has a important role in middle ear function, you are destroying that part. So there are some difference in opinion. There are so many research and their conclusions are there. But in our cases, in our day-to-day practice, we do cortical mastoidectomy when there is a infected middle ear cavity. The middle ear mucosa is hypertrophied and you cannot visualize the vessels over the middle ear mucosa, and CT scan or anything or X-ray shows some accumulation in the mastoid cavity. We open the cortical mastoid to check is there anything else is left or not. And then according to the need we do our tympanoplasty using temporalis fascia or cartilage. So this is the tip cell region we are drilling. This is the actual area of the facial recess, this area. So this is the lateral semicircular canal. You have to go anterior to the lateral semicircular canal.
Hello, sir.
Yes, yes. Tell me.
How can we identify the digastric ridge?
Yes, I will just show you how to identify. You will just drill the tip cell bone. Whenever you have completed the lateral tip cell bone and you are going to the medial tip cell area, when you really drill all the bones over the tip cell, you can directly identify the digastric ridge, because you don't have to drill or make the digastric ridge. It will appear by its own. You have to just continue your drilling. You have to just remove all the cells over there.
All right.
Okay, and
Alright.
this digastric ridge is a fantastic landmark for the facial nerve. So whenever you are doing the surgery, so you have to identify the facial nerve from behind. Then two landmarks are very important. First is the lateral semicircular canal and second is the digastric ridge, and the third one is the incus. I will show how you have to identify the incus and what is the role of the incus in delineation of the facial nerve in the mastoid cavity. So first we have to drill all the bones from the tip cell area. Okay.
Okay, sir.
And now you will get the digastric ridge at that part. You just continue drilling. So digastric ridge is basically the prominence of the attachment of the digastric tendon inside the mastoid cavity. It just identifies the landmark for the facial nerve at the stylomastoid foramen. So this is the mastoid area. This is the lateral semicircular canal, and when you are drilling in that part, always drill like that. Start your bar from medial and come slowly up to the lateral part. So always go medial to lateral, because if there is any jerky movement or if there is any, if your bar has been slipped from your hand or if you have a slippage of the hand piece, then it will go outside. It will not hit any important landmark medially, because all the landmarks are in the medial part. So you start in the medial part and come slowly to the lateral direction like that. Give water continuously. Okay, like that. So you will remove the bar, and now you have to drill up to the incus. You have to identify the incus, because this is one of the valuable landmarks here. That will not identify the incus, then you should not go for the facial nerve or posterior tympanotomy. First you have to identify the lateral canal, digastric ridge, the incus, and then only you should go for your posterior tympanotomy for the middle surgery or any surgery where you are not trying to elevate the tympanic membrane, but you are going inside the medial cavity through the mastoid by this combined approach tympanoplasty. So you continue drilling this part. Okay. Look, now give some water. You can just visualize the glimpse of the incus. Now you can visualize the incus, the short process on the body of the incus, and this is by the refraction of the water. Okay, look, this is the incus over there, and when I sucked it, you cannot visualize. So this is called the refraction test. If any structure is hidden just away from your visibility, then you put some fresh saline or water, you can visualize the structure by refraction of the water, and then you will have some idea that yes, your incus or your important structure is nearby. You can drill according to that situation. You should use a smaller bar, in a smaller bar. 1 second, we are just changing the word. This is not. Okay. So in that position, we will use some small bar to delineate the incus. And for that reason, we have increased our magnification to 0.6 so that we can easily visualize all the important landmarks. So this is the lateral semicircular canal, and that we have a diamond bar. So we have taken a diamond bar. Sometimes we do this using diamond bar. You can also use small cutting bar also in that region, but I prefer to use a diamond bar at very close to the important landmark like this ossicular chain here. If there is a slippage of the bar, you can definitely injure the structure, but if you have a diamond bar, the chances of injury will be lesser in comparison to the cutting bar. So whenever you are very close to a important structure, always shift to a diamond bar. Okay, so this is your superior part and this is the body of the incus. So here you will find the fossa incudis. This is the lateral semicircular canal. This is the body of the incus. This is the short process of the incus, and here the attachment is the fossa incudis. Okay, so now you have to go anterior, more anterior from that part. You have to drill that part slowly so that you can identify the IM joint, incudomalleolar joint. The water is not flowing. Okay, fine. So you have to go very slowly up to the.
Hello.
Yes.
Can you focus it more anteriorly, please?
Yes, tell me.
Can you centralize it?
Oh, centralize.
Yeah.
Now you can visualize.
Yes.
So how beautiful the structure. This is the full the incus, and look the ventilation folds or the mucosal folds that has been attached to the incus, to the superiority. This is the superior incudal fold. And just make your head slightly lateral so that you can visualize properly, and then go for anterior. We have just starting visualizing the IM joint, just anterior to that. Some water. So this much dissection is required majority of the cases, because you have some blockage whenever you are doing the cortical mastoidectomy, and this blockage of the ventilation pathway you have to clear, and then you have to dissect up to that part regularly, and that is called the posterior epitympanotomy. This is the epitympanum, and this is after doing cortical mastoidectomy. When you are going further anterior, the dissection is called posterior epitympanotomy, the opening of the epitympanum from behind, from the mastoid cavity, and you have to go up to the cog or up to the anterior part of the head of the malleus, and this is called posterior epitympanotomy. And then we will drill the cog, we will go anterior to the cog, and that is the anterior epitympanic space, and this is called anterior epitympanotomy. So after doing cortical mastoidectomy, when you are exploring the epitympanic cavity, the prime area of the middle ear where the ventilation fold and the ventilation pathway passes, and this had a two parts: the posterior epitympanum, that is posterior to the cog, that houses the ossicular chain, the incus and the head of the malleus, and then anterior to that, anterior to the cog, this is a small space that is called anterior epitympanic space, and both these spaces are very important for the ventilation pathway. And majority of the cases when hello yes
Hello sir, can you please show the cog?
yes wait for some time. Just we have to go anterior to the malleus by drilling some bone here, then we will reach up to the cog. Okay, and in that part you should be very vigilant that your bar should not touch the malleus or the incus. This is a temporal bone dissection, this is a cadaveric temporal bone, so there is no harm, but if your high speed bar touches the ossicular chain, then there will be a high chance of postoperative SN loss or high frequency sensorineural hearing loss in that patient. Okay, so now you are visualizing the ventilation fold that divides the anterior and the posterior epitympanic space and holds the ossicles. Basically the ossicles has been suspended from the segment by these ventilation folds. So this is the ventilation fold. Okay, so here is the body of the incus, here will be the cog. Okay, this bony structure is cog. Can you identify? Can you see it? Hello?
Ball.
Sir. So, this is the cog. Look at the structure. Look, this is the cog. Okay. So this is the malleus head and this bony structure that's coming from the tegment. This is the cog. And here was the ossicles and the ossicular band that holds the. So after that part you are going to the anterior epitympanic space. So this is the anterior epitympanum and here is the posterior epitympanum and this structure is the cog. We will remove that bone, then it will be more clearly visible the cog area. Okay. Look. Water. So can you tell me, anybody from the audience, what is cog and what is the significance of the cog? Hello? Sayan?
Ball.
Anybody from the audience, sir? If anybody want to add, what is the cog and what is the significance of the cog?
It is a bony projection from the tegment tympani to anterior part of the head of malleus.
Yes.
Significance, it is the demarcation between anterior and posterior epitympanum.
Yes. As well as it defines the first genu or geniculate ganglion of the facial nerve. So this is also a importance of the cog when you are doing the facial nerve decompression. And one more thing, the cog is the embryological remnant. The middle ear and the mastoid, when it develops in the epitympanic part, there is a succus anticus and succus medius. So this succus anticus and medius, when they communicate, when they join in the embryological life, the demarcation between this succus anticus and succus medius is defined as the bony projection, that is cog. So this is the embryological remnant.
Okay, sir.
Okay, how it is defined, and look, you can clearly visible, this is a
Yes,
cog,
sir.
this is anterior part. And if you Google it, the term cog, it means a wheel, just like a bearing. So there will be multiple projections that arise from the cog. So that helps to identify, yes, this is the cog. And for surgical part, this is very important. And nowadays, when the whole otology is shifting from the microscope to endoscope, and the anatomical relevance of the middle ear and the mastoid from the endoscopic perspective has been changing, this cog has a very important role, important landmark into the middle ear and the epitympanum. Okay, so we'll stop at that position. So this is your incus, this is your malleus, these are all the ligaments and the folds that suspended this incudomalleolar joint, and just anterior to that, this bony projection is the cog. If we remove the malleus and the incus, then it will clearly visible the anterior part, the cog completely. Okay, so this is the actual epitympanotomy. You can go up to the eustachian tube from that direction also, but we are not going so far at that position because you have to start dissection today, and we will demonstrate the key steps only for your ease. This is the cortical mastoidectomy. We have accentrated all accessible cells over here. Definitely we can drill so far in the mastoid tip area. We have to go far inferior, but before that we will drill this ridge area and we will define the posterior tympanotomy, how it is done and how to access the middle ear through the mastoid antrum without opening your tympanic membrane. So that is actually the benefit of doing posterior tympanotomy from this side. Okay, so now we will drill the ridge area. Okay, diamond bar 3-4 number this is slightly smaller. Okay, anybody you have any questions you can discuss at that part. Sam, if you have any questions from the audience. Yes. Okay, now start drilling the posterior part. No. Water. So we have to delineate all the cells from the posterior part of the canal wall, so then we can visualize the ridge area. So ridge is a straight bony septum part and is a thick bone. There will not be any cellular area over the ridge. So now these are the cells that we are delineating. Water. And we are going toward the posterior tympanotomy side. So for posterior tympanotomy, what is the landmark? So the basic landmarks of posterior tympanotomy or the basic area is the chorda tympani, the facial nerve and superiorly the incus buttress. Okay. So
okay,
for direction of the facial nerve, we have two landmarks here. One is our lateral semicircular canal and second is the incus. So direction of the thought process of the incus actually defines the area of the facial nerve in the vertical segment. So for that reason you have to drill all the cells and go up to the facial nerve. But in life surgery we rarely depend on the facial nerve nowadays, because in life surgery if you try to delineate facial nerve, there will be some chance of damage by thermal injury in a very pediatric age group because the bone is very thin. So for that reason we always use the anatomical coordinate to delineate the posterior tympanotomy site. Okay, and eventually some cases we actually define the chorda tympani in anterior part and into the posterior part the facial recess, the facial nerve also. So this is how we are drilling. Look, this is a thick area of bone and now this is the ridge area. Okay, so this is the bridge, this is the ridge. From the bridge there is a flow of water in the air beneath that, and this is a thick bone just below the lateral semicircular canal up to the tip cell or the digastric ridge. This is called the ridge. Okay, so this is the two anatomical landmarks. So here will be the fossa incudis and you will drill from that direction up to the mastoid tip area. So here will be your facial nerve.
Sir,
Yes.
kindly define the bridge and the ridge once again.
Look, this is the canal wall. Okay.
Okay, sir.
Here is the lateral semicircular canal. So
Okay.
the facial nerve will come from the middle ear floor to the mastoid cavity and go along the way up to the digastric ridge.
Okay.
So this thick part lateral to the facial nerve just below the lateral semicircular canal, this is called ridge. Okay.
Okay, sir.
And the bony part, this is the above the scutum area, in that region this is called bridge, because
Okay, sir.
below that there is a hollow space and there is a flow of the water and flow of the water. The bridge tolai ki jai, there is a flow of
River.
water of any river, that is called bridge.
Yes.
So that is the term arise from that. The bridge, there will be a flow of water and the ridge is a thick piece of bone. Now there are some cells that you will find during doing this posterior tympanotomy, and sometimes these cells are very helpful because this is the natural tract that goes from the mastoid to the middle ear, and that actually presents into the very cellular mastoid, and that is actually guiding you to reach the mastoid cavity. And look, give some water. You fill the space with the water, then suck this from the cellular area, and look, the all water getting sucked from this area. So that signifies that this cell tract has been a direct communication with the middle ear cavity. If you have damaged the external auditory canal and you have gone far anterior, then whenever you are sucking the water, it will not come through this opening. So this is a water test we usually do during doing the posterior tympanotomy in the live surgery. So this is the part you have to drill thoroughly, and always remember the direction of drilling, the direction of bar will be along the important structure, that is facial nerve. So like this, in that way. So go drilling slowly, and you will eventually identify the facial recess area. Okay. So this is the lateral canal. This will be the incus buttress. The incus buttress is basically kept to protect the incus, the short process of the incus, and secondly, it will hold the electrode after insertion. So in that case, you will have to keep your incus buttress intact for the live surgery. Now here you will find the chorda tympani. Here is will the, don't worry, give water. This is the facial nerve will be there. So this triangular space is the posterior tympanotomy. So whenever you are trying to go for posterior tympanotomy, always start from the superior part, very near to the lateral semicircular canal, because this is the base of the triangle. So the dimension is maximum at that area. Don't go at that level, because here will be the facial nerve, here will be the chorda tympani, so chordofacial angle will be there. So this is the narrowest part and this is the widest part. So always start your posterior tympanotomy in the superior portion, very near to the lateral semicircular canal, and make the incus buttress very thin so that you can directly enter into the medial ear without damaging this important structure, the facial nerve and the chorda tympani. Okay, and layer by layer you have to dissect, you have to identify all the landmarks. So this is the incus buttress, and we are going for medial to the lateral semicircular canal. So now there will be a chance of appearing facial nerve anytime. So always keep your eye on that area. Your focus should be on the tract of the facial nerve area. Okay. So now drill. So this is the facial nerve is coming. The first glimpse of first appearance of the facial nerve. Look. Okay. Can you appreciate? Can you visualize the facial nerve?
Absolutely.
Yes, so this is the first glimpse of the facial nerve. So facial nerve will go up to the tip cell in that region. So for posterior tympanotomy, this is not necessary, but when you are trying or doing a facial nerve decompression by transmastoid route, then this approach is very important. So the facial recess approach is needed where? So classical facial recess is for cochlear implantation. Second is the facial nerve decompression. So when you are doing a transmastoid facial nerve decompression, you have to do a proper posterior tympanotomy to reach the tympanic segment. And in that part, we have to sacrifice the incus buttress. We have to remove the incus so that we can visualize the tympanic part of the facial nerve. So for our transmastoid facial nerve decompression, we have to remove the incus buttress. But before removing incus buttress, first you have to open the facial recess area. Okay. Why? Because you have to open the facial recess, you have to enter the middle ear, water. You have to enter the middle ear, then you will dismantle the IS joint. You have to disarticulate the IS joint first, then you can remove the incus buttress and remove the incus, so that there will be no